the harmful medical errors. In the meantime, what's an apology? Is the apology a sort of admittance of fault? If I apologize to a patient, this means that I admit that I have done a fault. What about medical malpractice claimants? What about litigation? What about the apologies and physicians? Do physicians apologize more or surgeons? What are the barriers to apologies after medical errors? Are there effective guidelines for apologies, evidence-based guidelines for apologies? What are effective apologies and what is the receptivity of apologies in the medical profession? They increase nowadays. So, efforts to improve the patient safety remain an international focus in healthcare delivery. Adverse events and medical errors are a major health problem. Some consider that medical errors are preventable adverse effects, but as a matter of fact, this is debatable. As all errors are truly, it is debatable that all errors are truly preventable. In the meantime, we should differentiate between honest mistakes and negligent actions. So if it's an honest mistake, there is no problem. But if it's a negligent action, the surgeon should be file suit. Okay. If we have got a tight healthcare program, would this make the medical errors zero? No, never. It can never happen this way. Medical errors will continue to occur in spite of improving the quality of healthcare. How to disclose harmful medical errors and whether to disclose them or not to patients, this is a challenge as a matter of fact. So physicians should integrate their understanding of the following 4 items: the bioethics, the doctor-patient communication, and the team-based care delivery and the quality of care. As a matter of fact, efforts to improve patient safety remain an international course, an international focus in healthcare delivery. Anyhow, there is a general consensus among ethicists that harmful errors should be disclosed to patients. In spite of this, disclosure is uncommon. In spite of the general consensus that we should disclose it, but disclosure is uncommon, and it varies widely from one country to the other according to the culture. Ethical standards articulated by the American College of Physicians and the American Medical Association oblige the disclosure of errors. So in the United States and in Canada, it's a must to disclose the medical error, but in other countries, you've got the choice to disclose it or not. And this depends upon the culture of the people in which you are going to disclose. For instance, in some low-income countries, if a patient is in the intensive care and his case is doomed and he dies, sometimes the relatives of the patients beat the doctors. So would you disclose a medical error to such people? That's a point to be discussed. Anyhow, ethics focus on the necessity for trust between the physician and the patient. The relation between the physician and the patient is one that involves 3 items. There should be considerable intimacy, considerable vulnerability, and considerable trust. Medical errors, as a matter of fact, injure this relationship. As we said before, there are barriers to disclosure of medical errors. What are these barriers? First of all is the fear of consequences. Secondly, the fear of litigations. Thirdly, the fear of attitudes about disclosure. And finally, the lack of skills and lack of peer and institutional support. For instance, if you're working in a certain hospital or institution or organization, and they don't give you support to disclose the medical error, you're the only loser. You should look for support from your organization, and we should change our mentality as regard organizations or hospitals and things of that sort. What about compensation programs? As a matter of fact, compensation programs decrease the litigation. and improve the disclosure of adverse events. What do we mean by compensation programs? These programs encourage honest discussion between the physician and the patient about the event that occurred. Compensation may make disclosure less adversarial. Patients have rights and providers or physicians have responsibilities. So the quality of medical care can be enhanced by medical error disclosure. By compensation, we mean that we give the patient some sort of financial compensation. So this will decrease the litigation. Apart from financial litigation, you can waive the extra fees that he's going to pay in the hospital for the medical error that occurred. This diminishes the litigation and makes some sort of trust between the physician and the patient. What are the actions desired following an adverse event in the United Kingdom? In a survey done, 34% of the patients require an apology and explanation. As a matter of fact, this is the point of argue. A lot of physicians or surgeons, they do not apologize and do not explain to the patients. In the meantime, some patients endorse punitive measures for healthcare professionals following an adverse event. That is, they want the physician or the doctor to be punished. It's some sort of revenge. In the meantime, it is mandatory for healthcare organizations to report serious adverse events to external agency. That's in the UK. Finally, waiving of the additional medical fees, as I said before, as a result of an adverse event, and financial compensation for any injury, pain, or suffering caused the medical error or caused by the medical error. So financial compensation and waiving of extra fees is a must in the UK, and this diminishes the medical complaints and the litigation. When I used to work in the Royal Free Hospital in London, they used at the end of the year to give a book including all the medical errors that occurred anonymously. You don't mention the name of the surgeon or the physician for his dignity. The target of this is to avoid further recurrence. So the target is to avoid recurrence of the same error that may cause harm to the patient. This occurs in the air forces. For instance, in the United States of America, when a plane mishap occurs and anesthesia is like the plane, the most serious periods are the induction and the recovery, and this is like takeoff and landing in the airplane. So whenever a mishap occurs and the pilot is still alive, the pilot is always inquired in front of an accident investigation team, and his words are videotaped. In the meantime, the videotape is to avoid further recurrence. When he sits in front of official authorities, he can change his words and they can never use the videotaped things against him. So the target is not punishment of the pilot. The target is avoidance of further mishaps. Same thing applies to anesthesia. If we know the adverse events even anonymously, and that's what occurs in the UK, the number of mishaps will diminish. As regards the apology, is an apology a sort of admission of fault? If I apologize to the patient, this means that I've done a fault. How can we handle apologies effectively is an issue for error disclosure. Patient safety requires no secrecy of error, as I said before, for a doctor's dignity. This could be done anonymously. One way in which physicians can respond to a medical error is to apologize. And there's a great difference between an apology and regret, and this will come to forwardly. What's an apology? The apology should have 3 items. Apologies are statements that acknowledge an error, and its consequences. That's the first time, acknowledging an error, taking responsibility, and in the meantime, communicating regret for having caused harm. So, acknowledging an error, taking responsibility, and communicate regret. Does the apology improve the condition? Yeah, the apology may lead to it decreases the blame, decreases the anger, increases the trust between the surgeon and the patient. It improves the relationships. In the meantime, it decreases the risk of medical malpractice lawsuit as far as an apology occurred. In the meantime, it can help to settle claims by patients. As a matter of fact, patients expect explanations and apologies after medical errors, and this doesn't occur frequently. In practice, physicians tend to provide minimal information to patients after medical errors, infrequently offer complete apologies. And that is one of the main causes of file suiting or medical claimants. If they received an apology or an explanation, they wouldn't have filed suit. An apology is a statement given by one who has injured another that includes, first of all, recognition of the error that has occurred. Secondly, admits the fault and takes responsibility. Thirdly, communicates a sincere sense of regret for having caused harm. Is there a difference between an apology and a complete apology? Yeah. Complete apologies include promises to refrain from engaging similar conduct in the future. And this is one of the main targets of the patients or the relative of patients, is to avoid the same thing from happening to another patient. Secondly, a complete apology should include compensation for the harm that had occurred. Do apologies have positive effects? That's sure they have positive effects on the following items: expectations and intentions for a future relationship between the parties. Apologies have positive effects on restoring trust between the surgeon and the patient. They reduce the negative emotional reactions such as anger. In the meantime, they induce favorable psychological responses in both parties. And finally, they reduce antagonistic responses. What about apologies and patients? Patients worry about apologies of medical treatment, particularly outcomes that result from medical errors. In a survey, 98% of the patients desired and expected the following: to be informed promptly about a medical error, which doesn't happen; to be given information about what occurred, why and how it occurred, how their health will be affected, what steps will be taken to prevent future harm, and to receive an apology that signals a sense of regret. What about medical malpractice claimants? Vincent and colleagues surveyed medical malpractice claimants about reasons they file suit. Why do the patients file suit? Over 90% of those who responded indicated that they wanted to prevent the same thing from happening to someone else. So as I said before, the first target is prevention of recurrence. Secondly, to receive an explanation for what happened. Thirdly, for the doctors to realize what they had done. As a matter of fact, 40% reported that if they had received an explanation and apology, they wouldn't have felt the need to file suit. So, giving an explanation to the patients promptly after a medical error and an apology will diminish the file suiting to a great extent. What about litigation? Other studies have found that failure to provide explanations and poor communication are generally associated with litigation. The target is a desire to deter subsequent malpractice by the physician and to seek revenge. So the target from litigation is revenge and subsequent malpractice to be diminished or prevented. What about apologies and physicians? And who gives apologies, the apologies more, the physicians or the surgeon? As a matter of fact, physicians. As I said before, the physicians are affected by the medical errors like the patient and even more. So physicians are profoundly affected by medical errors. The physicians worry about harm caused to the patients. The physicians are anxious about the consequences for the error. For the following conditions: their reputation, they are afraid for their reputation, fearing that patients and colleagues will no longer trust and respect them. Thirdly, experience distress, feeling of guilt, self-guilt. The physician feels he is guilty if the mistake is not due to negligence. Fourthly, loss of confidence or loss of self-confidence. And finally, he is anxious from having a lawsuit. Anyhow, there is a wide variation in physicians' tendencies to offer apologies for medical errors. In one survey, respondents had experienced medical error in their family. Only 1/3 reported that they had received an explanation or apology for what had happened. So a lot of people, they don't receive an explanation and they don't receive an apology, and that's why they file suit. What about error disclosure by surgeons? In a study of error disclosure by surgeons, there was wide variation in disclosure practices. 57% referred to the error as an error or mistake. Others described the event as a complication or problem. So the way of disclosing the error differs from one surgeon to the other. So saying it's a problem, saying it's a complication, and in the regret, it differs widely from an explicit apology to saying, for instance, I'm sorry to have to tell you that so and so occurred. 16% didn't indicate that the outcome was preventable, and 65% took a responsibility for the error. In the meantime, 47% offer some expression of apology or regret to the patient. Expressions ranged from explicit apologies for the error to much less direct statement of regret. I'm sorry to have to tell you this, as I said before. Surgical specialists were less likely to apologize than medical specialists. In another study, 61% of the physicians would express regret for the adverse outcome, and 33% would apologize in a way that acknowledged the error, and 6% would offer no apology. The inclination to offer an apology was smaller when the error was one that would be less apparent to the patient. So if the medical error is unapparent to the patient, they don't offer any apology. What are the barriers to apologies after medical error? First of which is fear of litigation, fear of legal liability. In the meantime, to admit that an error has occurred and to apologize for it is embarrassing and injurious to one's pride. So the surgeon feels that his pride is going to be injured if he admits the error. Lack of certainty and skill about how to go about disclosing error and apologizing for them may prevent many physicians for engaging in such conversations. So as you said in the very start, that disclosing the medical errors needs special skill, and now it's even in the curriculum of some medical school how to disclose medical errors. What are effective apologies? Apologists that accept responsibility for having caused harm are more effective than similar expressions that simply express sympathy. So, if the apology is accompanied by an offer for compensation, this can influence its impact. As I said before, financial compensation is a target for the patient and his relatives as far as there is a medical error. In the United States, the National Quality Forum puts forward an evidence-based safe practice guideline regarding the disclosure of serious unanticipated outcomes. And this is very important. So we have got evidence-based guidelines. What are these guidelines? First of all, disclosure should include, or disclosure of medical errors, an explanation of what had happened, the implications for the patient. Shall this affect the future of the patient or not? In the meantime, there should be a commitment to investigate and feedback about such investigation. So if the cause of what's occurring in the patient is not clear and is not due to a medical error, further investigation is required, and feedback for this investigation to the relatives of the patient is a must. The guidelines advises physicians to express regret to the patient, regret and not apology. This is when the adverse outcome, when there is an adverse outcome and not a medical error, and to apologize when there has been an error. So this should be very clear. The guidelines need regret when it's an adverse outcome and apology when there is a medical error. What about the receptivity to apologies in the medical profession? There is an increasing receptivity within the medical profession to apologizing to patients who have been injured by medical errors. Some medical schools are now starting to incorporate training about error disclosure and apologies into the curriculum. And as is apparent, medical errors are the third leading cause of death after heart diseases and cancer. So it's something worth. What about the receptivity to apologies in the medical profession? Incorporating apologies as part of the disclosure of medical errors can benefit both partners, the patients and the caregivers. An apology that accepts responsibility for an error and the harm caused may be most appropriate when it is clear that an error has caused harm. So when an error causes harm, an apology is a must. If the adverse outcome was not the result of an error, an explanation of the cause of the complication coupled with an expression of regret for the outcome and sympathy for the patient condition seems more appropriate. So to make it clear, if the guidelines, the evidence-based guidelines indicate that if the adverse outcome is not due to an error, a sort of regret and sympathy should occur to the patient. But if it was due to a medical error, an apology is required. Sincere apologies. Sincere apologies for a medical error may lead to lessening of suffering for both patients and physicians in coping with the error and its consequences, contribute to improved relationships between physicians and patients, reduce the costs by preventing lawsuits, and it facilitates the settlement of valid claims. So if there are valid claims, you can settle the condition. So sincere apologies is a must, and it improves the condition very much. Take-home message. Both healthcare professionals and patients support the concept disclosing adverse events when they occur. So both partners accept or support the concept of disclosing the adverse events. Despite this agreement, disclosure is still far from universal. In the meantime, adverse events are increasingly recognized as a source of harm to the patients. Problems arise in communicating the situation to the patients and their families, and there is a great variation between countries in disclosing adverse effects. As I said, it depends upon the culture of the patient and his relatives. In some countries, it is obligatory, like in the United States and Canada. In the meantime, organizations' policies as regards disclosure of medical vary widely. Healthcare professionals should be assured with hospital disclosure policies that they will be supported by the institution in disclosing the adverse events. Increased openness and honestly following adverse events can improve provider-patient relationships. In the meantime, patients want assurances that they will not suffer financially due to an error. So as I said, waiving of the financial fees for any medical error that occurred, as it occurs in London, and a sort of financial compensation. Fear of medical malpractice and litigation has been identified as an important barrier to disclosure. Physicians desire training to handle adverse events. Thank you very much for listening.
Prof, thank you so much for this very informative and interesting lecture in the field of the ethics of the anesthesia and how to deal with these adverse effects. And I think to apologize for the family from, as you said, and as you mentioned, Prof, from the side of the anesthetist, we should encourage ourselves to this culture. And I think we have some of the questions written here. One of our colleagues is asking, in some developing countries, the patient's family doesn't accept ability of the physician. I think apology of the physician if an expected complication is inevitable. Some patients with multiple and severe comorbidities. What is the right way, Prof, to avoid litigation?
Well, as I said before, sometimes even if the doctor is honest and the patient dies in the intensive care and his condition is very severe, sometimes the relatives beat the doctor. It happens. I said it depends upon the culture. And when I'm speaking, I'm not speaking about anesthetists only or intensivists only, but even surgeons and physicians. So the proper way is to be very frank with the patient, but according to his culture. Or you choose someone of those who are cultured or educated in the family and tell him the facts. This increases the trust between both parties. And if you offer compensation and you waive the extra medical fees, he will accept this because they can't afford to pay.
Prof, I have some of comments and question, if you please.
You're most welcome.
Regarding, thank you, sir. I think all of us in our field of experience, we met some of the medical errors by ourselves or by our colleagues, and we heard about fatal medical errors like infusion of potassium, for example, or insulin by error. And this may lead, or not may lead, leads to the morbidity and for
mortality.
the patient.
Even it may lead to mortality. You give adrenaline instead of atropine.
Yes, for mortality. And I think the communication between the anesthesiologist and the pharmacy is one of the most important items for declaration of the drugs, for putting, for example, high alarm or just marking of coloring marking for the drugs to avoid of some of these errors. One of also of the most important educational method to learn and to teach from the medical errors is the meeting of mortality morbidity, I think. What do you think, Prof, about this?
I agree with you absolutely. Concerning the mixture of drugs together, as you said, you've given the answer yourself. You've got tapes, colored tapes to avoid this. For instance, muscle relaxants have got a certain tape. Narcotics have got another colored tape. So in this way, we can avoid this. Apart from this, it is to be noted that the anesthesiologist is the one responsible for the drug he gives. So a lot of us let the nurse or any other one prepare the drug for him. You should see at least the empty ampoule, at least, because medico legally, you're the one in charge and the one responsible. As I said before, the target is not punishing of the anesthetist. The target is to avoid further recurrence. So as you said, if we make conferences concerning the mortality and the morbidity that occur, sometimes in some places they make a weekly conference. And as I said before, if you give anonymous cause of mortality or morbidity and discuss it in this way, you'll improve the condition.
Prof, another comment regarding to our juniors, regarding the residents and our colleagues. Do you agree with me that the overload, sometimes the overload on the on-call or in the list may lead to this error? We should help our juniors and give them the time for teaching, for learning, for giving them some of the hours for teaching them and giving them the chance to take rest or breaks, not to make overload for our juniors, because this may lead to this event and mishaps. And if this happened, Prof, is it the responsibility of the junior in the room or the senior and the juniors?
Well, from the legal point of view, it is the responsibility of the junior. It's not the responsibility of the senior.
The junior.
Yeah.
Okay.
As far as the senior didn't give him the proper way of handling things. As a matter of fact, anesthesia in itself forces some of the junior staff to work day and night because the fees of the anesthetist is not promising. And he's got a family and he needs money. And as a society, we met the Minister of Health and Medical Syndicate, the Dean of the Medical Syndicate, but unfortunately, we didn't manage, it's a complicated problem. We didn't manage to raise the fees of the anesthetists. And as a society, I'll tell you something. For instance, one of the junior anesthetists anesthetized a case of cesarean section. He gave spinal anesthesia in a private hospital in the countryside, and the private hospital is just 2 apartments in a building. And then they asked him, there is another private hospital in the building beside, and there was another cesarean section. So they asked him to give anesthesia. He just left the first case and went to give spinal to the second case. They told him that the first case is suffering, and he went, the first case died, and the second case died, and he came to the society telling us to give him a letter that he hasn't done a mistake. that makes no sense by all means.
Very
But
bad scenario.
yeah, it's something horrible. But as I
Yeah.
said, uh, the conditions of the anesthesia as fees forces some of the junior staff to do so. Another case, for instance, one has given spinal in a clinic, and then it turned to be total spinal, and there was no anesthetic machine in the clinic. The patient didn't die, but suffered from total mental confusion. The relatives of the patient said, "We don't accept money. We want the doctor to be in jail." And finally, he gave them money. He gave them all what he's taken during all his life. So that's a point to be put in mind.
Big point.
Another thing I'd like to say, uh, the, the consent is very important to the anesthetist. He should take the consent, however, he is busy. And I'll say something that happened to me personally. There was a wife who's had 5 children, and she entered because she suffered from biosalpinx or hydrosalpinx. When she entered, she had 5 children, her husband was present, her mother was present, and the doctor asked them, let's make hysterectomy in the same session. She's done hysterectomy. She was raised in a British school. She got her sheet. She managed to receive her sheet. And she asked me a very frank question. Did they do hysterectomy for me? I told her, yes, it happened. Why? To save you taking anesthesia for 2 times. She said, couldn't this operation be postponed for 1 week or 2 weeks until I recover? I told her, yeah, it could be postponed. She filed sued us all. And she said, neither my mother nor my husband has got the right to sign the consent for me as far as it is not a life-saving measure. So we should be very cautious as regards the consent, the medical consent.
If Prof, something happened related to the surgical maneuver.
Yeah.
And I am the anesthetist, of course, in the room. I'll be included in this mishaps.
I didn't get the question. Please repeat it once more.
If side effects or the surgeon, he did mistakes.
Yeah.
Is it my fault as anesthetist? I'll be included should be apologize for the family or will be included in this issue?
Well, I'll tell you something.
I mean, the fault or the medical error is away from the anesthetist.
I know, it's the surgeon.
Yes.
It happened once with me personally. The surgeon was doing laparoscopic cholecystectomy. And he was one of the very brilliant surgeons. But in the meantime, he injured the artery and the patient received 10 packs of blood, fresh frozen plasma, and so on. And the operation, instead, he used to take 20 minutes. It took over 6 to 8 hours, and the patient died. The surgeon told me, I'll go to his relatives and get it to them smoothly. I found the wife of this general doing the operation came to me and told me, the surgeon told us that he finished the operation and he gave us the gallbladder and that they are wakening him from anesthesia. Imagine what happened. So I asked the wife to get if she's got a man with him, with her, and I got the man into the operating theater. I showed him that still the patient was on the operating theater, dead and not closed. The window was still open. And I kept the jars that contained the blood. I kept all the jars. And this way, this general, he went to pension. So we should be very cautious from surgeons. They will never support you. They will never support you. But in the meantime, if the surgeon and the anesthetist won't be one hand, they might suffer both of them. For instance, in mishaps in airplanes, when a mishap occurs, they differ. The pilot from the assistant. so that they wouldn't prepare the words, and they take the words from each one separately. That's a way to know the truth. So if the surgeon and the anesthetist, uh,
Coapted.
yeah, they'll both suffer. They'll both
Yeah.
suffer. But the anesthetist should be very cautious because the surgeon will never support him. He's looking for his name, for his dignity, for his attitude, and he'll tell you, I am known, a well-known name, the anesthetist is unknown, so I'll get it in anesthesia. This is never accepted nowadays because the people now realize that the anesthetist is something different. The anesthetist is in charge of intensive care, in charge of anesthesia, in charge of pain relief, and the people started to ask for the name of the anesthetist before the search.
Yes. Yes. I think we should pray all together to avoid and to be away from the medical error, because this is very dangerous for us and for the patient. We have some of the comments, Prof, from our senior professor Salah Al-Tallawi from Minya University. You know him well, and he is my senior. He is mentioning that he thinks that the culture is completely different in our area, and it is difficult to implement such value guidelines in our society. And also there are some barriers that make this difficult. The most important is the lack of documentation or fabricated documentation. What do you think, Prof, about this comment?
I agree with him absolutely. And I said in the very start, the cultural difference from one area to the other. But I'm speaking about, for instance, those working in Cairo or working in Alexandria. Some of the people are well cultured and they have got the right to know what happens. It differs from, and I said before even that they beat the doctors because of the bad culture. So he can't disclose errors with such people, But in the meantime, such people will file suit him if a complication occurred. So he should try in whichever way to gain their trust.
Okay. What if pneumothorax during CVB insertion, should I tell the relative, ya Prof?
Excuse me?
If pneumothorax happened during CVB insertion, this one of our question, should I tell the relative, and how can I tell them?
First of all, that's a normal complication. It happens. It's not a medical error. You don't consider it, it's recorded in books. So it's not a medical error. I should disclose the condition, and the patient, as far as it's diagnosed in the proper time, the patient will recover.
Okay. I think for this, we can stop for taking questions, because there are a lot of questions, because this is very interesting lecture and very rare to listen about the side effects and the error during medical errors, and how to avoid these medical errors and disclose medical error. So thank you so much, Professor Nabil, for your time. And we appreciate this very informative lectures. And now our audience, please, the floor for Professor Yasser Zaghloul to introduce our next speaker. Thank you so much.
It's my honor and delight to be with you, and I find no words to express my sincere gratitude to all of you.
Thank you.
You may end your sharing. You may end the sharing of your Professor Nabil.
Okay, I'm with you.
Your screen, please. Yeah.
Okay, thanks a lot.
Well, yeah, okay, it's fine now. Yeah.
Thank you, Professor Yasser.
Okay. Welcome, everybody. And now we are going to our next speaker, Dr. Rory Beige. Actually, Dr. Rory Beige, he was my senior consultant about 15 years ago. And now I am very honored to present him and for the next lectures. Professor Rory Beige is a consultant of anesthesia and the head of the department in the Cavan General Hospital in Ireland. and at the moment he is a council member of the
نعم
College of
لا لا خلي
Anesthetists in
أنا أسمع
Ireland
المحاضرة اللي ممكن
for hospital inspection program. And his talk today about the anesthesia, age, and the brain. And is it good for us or for me? We don't know. We will see the answer of Professor Rory Beige. Just before his lectures, I give very, very, very short notes about Kevin. Yeah. I know somebody maybe don't know what is Cavan exactly. It is in the north of Ireland to the south of the Northern Ireland. And it is about 116 kilometers from the largest city in Ireland, Dublin. This is the capital, of course. And this is about 2 hours drive Dublin to Cavan. And actually, Kevin is very nice town, and I have very lovely memories in the Kevin General Hospital with the hospital staff, with the nurses there, with the people living in the Kevin General Hospital. Actually, Kevin General Hospital has a very busy maternity unit. That's why very advanced anesthetic services to cover these maternity and obstetric very busy units. So you may ask why it is very busy units. We can see from this report, Ireland has the highest birth rate and the lowest death rate in the Europe. That's why we have most of the hospital dealing with the obstetrics usually is very busy because of this high birth rate. So this is very short about Cavan and Ireland, and we will come to our speaker, Dr. Rory Beige. Welcome, Dr. Rory Beige.
Thank you, Yasser. Okay. Okay, thank you, Yasser. I hope you can hear me.
Yeah.
Yes. Hello? Can you hear me? Hello?
We do hear you, but we need the voice a little bit more, please.
Can you
Yeah.
hear me now?
Yeah, that's better now.
All right.
Thank you.
Okay. All right. So where do I start? Well, first of all, I'm going to have to correct Professor Zaghloul and tell him I'm not yet a professor, but still Dr. Rory Page. But I'm very happy and very pleased that you've introduced me in such a very kind manner. And you've told me something about Cavan I didn't even know, and about Ireland and maternity services that I had somewhat forgotten. But anyway, so I have to give thanks to Dr. Saad Mahdi and the Academy organizers for the invitation to speak on this topic. So hopefully I'll try and speak as clearly and as slowly as possible so that everybody can understand my Irish accent. So it's also a very good, I'm very pleased and honored to follow Professor El Ascalani's talk, which was very erudite and even I found illuminating and very interesting. It's a very important topic to mull over every so often. So to the topic at hand, anesthesia, age in the brain. I think it's a very important piece for anesthesiologists to think about, particularly those who provide any pediatric care and certainly care for their elderly patients. And of course, many childhood anesthetics involve minor superficial procedures, and they're quite often done in non-pediatric centers. And so it involves very, very, very many anesthesiologists. And hopefully in addressing this issue, I'm going to hope to conclude a relatively neutral position on anesthesia and any potential neurotoxic effects. The other important reason I thought this was a good topic to talk about is that this is one that comes up or could come up in written or oral examinations to test what we now call the professionalism of the candidate. And certainly in relation to patient and parent communication. And this actually follows very closely on Professor Ascalani's talk on consent. Hopefully you can see my screen, can you? Hello?
Yes, sound, and you may share your screen, please, Dr. Beige.
Can you see my screen?
Share your screen, yeah.
Oh, yes, please.
The
Oh,
slide.
sorry, beg your pardon. Here we go. So,
Oh, okay, excellent.
all right, okay. I'm going to go back a long time ago, even before I knew Dr. Zaghloul. And I think maybe some of you can think that have similar recollections or similar experiences. But certainly my first weeks in anesthesia could end up quite hazy. And I can remember coming home and, or in fact, I can't remember coming home. I'd come home and sit in the chair. I've been told that I'd nod off or sleep in the chair, or I'd go asleep during a phone call. And I certainly hold that this is related to the effect of exhaust gases after a long day's session over semi-open systems, doing ENT cases or quick urology cases. And so once I finish this lecture, perhaps I also have to watch my brain as I get a little bit older after all this exposure. So I'm going to start in 2015 and with this consensus statement. So in October of 2015, a lot of the North American societies were enjoined by the World Federation of Societies of Anaesthesiology to publish this advisory public notice. And the word public is important because it's available to it was made available to parents and guardians alike. It alludes to the possible effects of anesthesia on young children and by inference, the developing brain. And it is directed at healthcare professionals and parents to the current state of science research. And it reinforced, it does reinforce the positive need and in general, the acceptability of anesthesia for important surgical events in a child's life. But just as the good professor was saying, it does encourage open preoperative discussion on the risks and benefits around anesthesia and especially with the new scientific data available. And the other important piece of this document is that in the parents' reading section, it uses the term harm. And this lays open a very thorny issue and a very emotive issue for parents and guardians of children. This website, this advisory notice also gives reference to a very worthwhile website called smarttots.org and is well worth looking at, recommended. And this is updated every so often, both for professionals and for parents. So very briefly, we believe anesthesia has always been taught as a balancing act between a favorable and least physiological interference while promoting its benefits. And we believe that the target organ or the target system in anesthesia is the brain and CNS. This has been certainly has been quite difficult to study, but nonetheless, newer methods and innovations have allowed clinical science to peer into the working brain, even the working brain during anesthesia and surgery. The virtues of anesthesia that are promoted are analgesia, amnesia, and they include certainly lately its antineoplastic effects. However, we can't ignore the physiological derangements that often need acute management, and we are kept constantly aware of its impacts on the respiratory and cardiovascular and even renal systems. And we've even come lately to understand that it has effects on the immune and the neurological system. Anesthesia, as we know, works on that target organ, probably through a multiplicity of actions, and probably through a multiplicity of receptors, namely the opiate, benzodiazepine, barbiturate, cannabinoid, and NMDA systems. But the final common effect that we want is induced coma or sedation. But that should never be confused with sleep, because it does not contain the REM or the non-REM sleep patterns that we commonly associate with normal sleep. And it also does not preserve the normal circadian rhythm. So for the next little while, I just want to talk about the evidence of any neurotoxic effects of the anesthetic agents that we use in common day-to-day practice. And I'll try and explain these with the associated biochemistry, the animal models, and then try and allude to the clinical translation of a lot of these pieces of evidence. So while we're doing that, we must always remember that clinical issues such as behavior are very hard to attribute to anesthesia alone, particularly against the background of surgery, surgical type of surgery, the duration of surgery, and of course, systemic inflammation, which has its own effects. This article on screen is a review article way back in 2006 by two very well-known or competent researchers called Mervicic and Levi. And they have used anesthesia as a means to understand the principles of inherited mitochondrial disease and how it affects metabolic pathways. And in the body of the text, they discuss the toxic neuronal effects of agents and how they are promoted by blocking key metabolic steps in the cell. And this happens regardless of the age of the cell or even the stage of its development. So within the discussion, they have proposed this very simple schema of the biochemistry pathways that occur within the mitochondria. And as we know, the mitochondria is the powerhouse of the cell. And the systems, as we know, are the oxidative phosphorylation system. I'm not going to go into great detail, but enough to say that there are 4 steps within the process. And each step is comprised of its own complex of enzymes and enzymatic processes. And as you can see, there's complex 1, 2, 3, and 4 in Old Roman numerals. So it is known that anesthetic and sedative agents can inhibit more or less all or one of these complexes. So in mitochondrial disease, this is deleterious, where already one of these complexes is genetically muted or absent. But it is also to some degree undesirable, even when you have normal in the normal setting. In other words, where the complexes are not absent and appear to be working normally. So as the system is blocked at all levels, the precursor
sound, please, Dr. Rory Beige. Sound.
Can you hear me?
Yeah, because many persons can't hear well. So, okay, thank you.
Beg your pardon. Can you hear me now?
Yes, more clearly, please.
Okay, sorry about that. Okay. So we've just dealt with the oxidative phosphorylation system and its importance, and that there are 4 steps, and that consequently we believe that anesthesia works on these 4 steps, and consequently as these enzyme processes are blocked, we get precursors being built up within the mitochondria and eventually in the cell matrix. And this in turn becomes cytotoxic and induces a condition called apoptosis. Very briefly, apoptosis is a universal enzymatic mediated process for cell disposal without causing damage to surrounding tissues or other surrounding cells. It's present in all organs and almost universally present in multicellular organisms. And it is seen to help order the development of embryonic organs and is present throughout adulthood and subsequently is part of the aging process. The key characteristic of apoptosis is it's not a disease per se, unless it is accelerated or disorganized. And one of the most important markers of apoptosis, or one of the most important laboratory markers, is the measurement of an enzyme group called caspases. And these are important mediators of intracellular apoptosis. And of course, they can be used as biomarkers, as I said. Unfortunately, during anesthesia, this what is seen in neuronal tissue appears to have an accelerated phenomenon related to apoptosis. Very briefly, and I'm not going to go into the details of this schema, but to say that there are two essential pathways to apoptosis. The top row indicates an extrinsic pathway, which is quite often related to lymphocyte induced apoptosis. And the bottom row is called the intrinsic pathway, which reflects oxidative stress. In both conditions, the final pathways relate to adaptor protein induction within the cell matrix, which eventually which goes on to stimulate the caspase cascade system, which leads to cell shrinkage and DNA accretion. And the cell is eventually disposed of. So the issues for us this evening is, does this happen with anesthetic and the sedative agents alone, independent of the surgical stimulus, surgery, surgical type, and inflammation? And what is the clinical significance of this potential neurotoxicity, if any? And if there is felt to be any potential clinical significance, is there a mitigation strategy? In other words, can we somehow modify this or reduce it or eliminate it? So in the next little bit of the talk, we'll review some of the evidence, and it'll touch on some of the animal models and clinical translations that have been looked at. And we're cognizant, of course, that all clinical models are fraught with the extraction of the clinical effects of anesthetic agents from surgery and other disease modifiers, as we've already alluded to. So this is the seminal article that probably kicked off a lot of the debate in recent years, and it actually goes back to this journal, the Journal of Neurosciences, in 2003. And Todorovic is a well-known researcher in this area, and she found that she examined the rat model exposed to benzodiazepine, namely midazolam, isoflurane, and nitrous oxide, and examined their rats with a complex behavioral measurements, and at post-mortem they looked at brain histology, and they concluded that there were behavioral changes in their study group of animals, and that associated with this behavioral change, there was marked neurodegeneration throughout the rat brain studied. So we'll fast forward 10 years later. In 2013, a very similar study was taken on by this group, Carla Uede, and she looked at a mouse model, and they were trying to show, and they did, that alcohol and anesthetic drugs exert a very similar behavioral and histological changes in mouse brain. And these were especially accentuated in the presence of caffeine, which is nowadays a very common food and drinks additive that, and particularly that children and adults will quite often use. One of the noteworthy observations from this study was that the mice appeared hyperactive as occurs in ADHD in the human model. So from this study, I have taken the slide, and it demonstrates, I think, very well the histological results that they have commented on. And this has been very much an observational effort. The brain tissues were stained with silver staining for apoptotic areas, and the staining density can be measured either visually or with a software program, much as radiologists do with CT scans. The picture here shows the clear architecture in the top left control group. Some subcortical densities associated with apoptosis appear in the caffeine alone group, and both cortical and subcortical with diazepam and isoflurane. However, on the right-hand column of histological slides, these drugs have been administered, co-administered with caffeine, and the conclusion was that caffeine certainly seemed to synergize the effects of apoptosis of the benzodiazepines and isoflurane. Some people, or there was some suggestion that this may even have been caffeine affecting drug clearance of diazepam and isoflurane and allowing them to have their apoptotic effect. More animal studies. So in 2012 and separately in 2014, both in anesthesiology, two separate models, two similar models were looked at. These were macaque fetal model studies, where macaque mothers were given either in the 2012 study a ketamine infusion over 5 hours. And in the 2014 Creeley study, they were given the mothers were given inhaled isoflurane for up to 5 hours. The slide indicates, again, I think you can see these dark dots occurring in the 2012 study, which indicate apoptotic areas, and this is again stained with silver staining. And this is occurring both cortically and subcortically and throughout the brain, the brain tissue. So they concluded that that fetal apoptosis was promoted by ketamine and isoflurane, and this remains a signal for toxicity of these agents. So so we will go and look at, is there any clinical translation of these purported apoptotic events? And DiMaggio in 2011 reported in Anesthesia and Analgesia that from a study comparing siblings, and these were who underwent general anesthesia and surgery versus those siblings in a family who did not, and they actually enrolled quite a number of children. But the obvious limitations of this study was that the controls may not have been quite matched for age and the type of surgery. It was just that they were siblings and that they had surgery. But this and as we know, surgery carries in its own right a marker and an inflammatory for general inflammation. So what they did actually show from this study was that at least when they compared other markers for potential neurobehavioral disorders in children that, for instance, complicated birth had carried a 1.5 chance of neurobehavioral disorders over the normal background of an associated effect. And similar, just being a man or a male child made you that little bit different. However, the important characteristic here that they were able to determine was that any child who had undergone anesthesia with any of the surgeries mentioned 3 or more times before the age of 3, this was associated with a very stronger and observable developmental and behavioral accumulation of developmental and behavioral issues. The question arising from this paper is this nature? In other words, is it a physical effect or is it nurture? Is it a functional effect? Is it just a factor of children being afraid and not being happy with their lot? So I found this article, which was quite interesting. I will not attempt to pronounce the names because they're not very easy to pronounce, but it comes from the very prestigious and American Academy of Pediatrics journal, and it was reported in July of 2015. And this is a very interesting and simple, elegant study, although it required MRI. And what they did was they looked at a very small portion of IQ testing, which has to do with language comprehension, and applied this to children who had undergone anesthesia and surgery. And they looked at MRIs, brain MRIs, after their anesthesia and surgery event. What they very elegantly showed was a negative correlation between the actual gray matter volume, particularly in the posterior brain regions, and this portion of language comprehension. And this tends to suggest that this is not just a functional effect, but there is a physical component to what is being observed. In other words, their brains had got a little bit smaller. So we need some good news. Saul, in this editorial of 2016 in Anaesthesiology, agrees that there is a potential for neuronal and glial cell apoptosis in the brain, particularly in the developing brain, but that animal models also suggest recovery of cell numbers over a much longer period after isoflurane exposure specifically. And he also suggests that this may be occurring in the adult brain in a similar fashion. So hopefully that this loss of volume that we've seen in the previous slide in pediatrics may be a temporary event, but that hasn't been tested. So Dr. Todorovic once again entered the ongoing debate, and she wrote an editorial for Anaesthesiology in 2018. And she is still insistent on the observable CNS tissue effects and the possible related behavioral changes associated with these apoptotic events. She warns that the United States FDA still requires open discussion of the risks and benefits with parents, caregivers, and even pregnant women around the use of these drugs. However, the paper does not advise as to how a conversation should flow. In other words, how you approach this subject, and what emphasis do you place on the risks. So while these editorials were deliberating over the issues and the potential hypothesis and theoretical events, an international multi-center trial was already starting to conclude with more precision. This was a study which looked at the effect on infants of general anesthesia versus awake regional anesthesia for surgery. Generally speaking, superficial surgery, such as hernia repairs, orchidopexies, etc. It was conducted in North America, UK, Australia, New Zealand, Italy, to name some of the countries. And they managed to enroll 722 randomly assigned infants for surgery that was of less than 1 hour's duration. The children were then followed up with quite detailed psychometric testing, which I'm not going to go into here. And they were followed up for a period of up to 2 years, or to the age of 5. And interestingly, they concluded that there was no perceptible difference between the two groups. And I suppose this is reassuring for the anesthesia community. But it still does not negate the basic science research, and it doesn't quite counter some of the professional bodies' statements that were already in the public domain, namely using the word harm. The study finally has asked for a more balanced epidemiological study, and because of the types of surgery, there was a high preponderance of male infants within the study, and they would like more inclusion of female children in future studies. So finally, in these islands, the professional bodies joined last year, and they created this statement. The bodies in this instance were the Association of Anaesthetists of Great Britain and Ireland, the Association of Paediatric Anaesthetists of Great Britain and Ireland, the Royal College of Anaesthetists, and the College of Anaesthetists of Ireland. Or should I say now the College of Anaesthesiologists of Ireland. Again, it doesn't dispute the significant studies and their implications. It assures parents and the general public of the necessity of anesthesia when it is clinically indicated, and that the epidemiology, they feel, does not show clinical translation for short single surgeries under general anesthesia. And this seems to be in keeping with the epidemiology. It also, interestingly, unlike the earlier public statement by the North American societies, it does not regard discussion of the neurobehavioral issues as mandatory at every consultation. But it seems to leave this open to suggest that it may sometimes be appropriate to discuss these. So overall, this has been a somewhat challenging but reassuring piece for providers of pediatric care, if not for the children's parents. But I suspect the role of media headlines will play an important impact in the future, and particularly once COVID is no longer the medical topical of the day. And our ability to present this complex issue to parents and even to colleagues in other specialties may become very important. And one of the practice areas to watch is perhaps in obstetrics, given the very small risk, if any, to the neonatal brain general anesthesia section. Anyhow, the issues have really centered around the developing brain, but I'd like to ask a question about the shrinking or even degenerating brain. Is there a risk? Will there be a risk for me? An important question when we are operating on more elderly people, and our elderly populations are increasing in some of our countries. A seminal article from 1955 in the Lancet by Bedford et al. Is still quoted by colleagues in psychogeriatrics, neurology, and general medicine. And it's proposed, and this article proposed an association between decline in everyday living and anesthesia and surgery. And of course, this did not look at the difference, or did not separate out anesthesia and surgery from many of the physiological disturbances that do occur. So I'm going to, without any further ado, have a look at some of the evidence of the impact of anesthesia on the elderly brain. Dong et al. Looked at apoptosis once again in human cell lines. And they also looked at beta amyloid production and when these human cell lines were exposed to a well-known anesthetic agent, sevoflurane. Beta amyloid, as we know, is a protein that is associated with Alzheimer's disease and is quite often found in its pathology of CNS neurofibrillary tangles. And the message from this article is that, yes, there seems to be a positive association. So what we're seeing here on this slide, on the left-hand side, are the electrophoretic bands showing denser caspase in relation to exposure once these cell lines have been exposed to sevoflurane. And there is also denser beta amyloid electrophoretic lines. The right-hand part of the slide just is a means of giving some sort of mathematical expression to the cumulative expression of these densities. But in either case, it does show an increase in both markers. So Dong et al. Concluded that patients with vulnerable brains may be at risk, particularly in long-term or cumulative anesthetic exposure. Now, these were in human cell lines and not not by any means in live human subjects. A very similar study took human cell lines as a study model, and they exposed these to isoflurane and also measured apoptosis and beta amyloid production within the cell lines. And once again, these are the electrophoretic patterns that had been produced, and they concluded that, like Dong did in sevoflurane, that capsase was being both capsase and beta amyloid were being promoted in these cell lines once exposed. So, to give an Irish flavour to the meeting, this is an interesting article produced by Dr. Sinead Savage, who is an Irish Sciences graduate and currently a research lead in Manchester University in England. And in writing a review in Brain Sciences, she talked about the possible putative mechanisms for nitrous oxide neurotoxicity. Interestingly, many of these mechanisms we are aware of as anaesthetists already, particularly the block at the methionine synthetase with subsequent abnormal vitamin B12 metabolism. But she also referred to the fact that nitrous oxide has effects on calcium transporters and subsequently apoptosis marked by increased caspase activity, much as in the earlier articles. So does this translate clinically? Well, we are all very aware of perioperative cognitive dysfunction as a described entity. It appears much more significantly in the elderly population and has a number of contributory factors, such as, again, surgery, the type of surgery, the duration. Obviously, cardiac surgery has an increased risk because of bypass. Pre-existing disease has an impact, and of course, the direct effect of anesthetic agents. So Steinmetz et al. have shown that at least the depth of anesthesia, as measured by BIS monitoring, is associated with an increased risk of perioperative cognitive dysfunction, implicating therefore the anesthetic agent. So whether this dysfunction is associated with a long-lasting decline seems to be more a function of pre-existing cognitive dysfunction. So there is there appears to be reversibility. And certainly in anesthesia and surgical circles, most people would feel that perioperative cognitive dysfunction, as unpleasant as it is a short-lived and reversible phenomenon. However, as I said a little earlier, this contrasts with many of our physician colleagues certainly in the psychogeriatric community, who still adhere to the old Bedford study of 1955, when in an era of less well monitored anesthesia and perioperative medicine. So in Ireland, as late as August the 31st, we live in post-COVID times. Well, not quite post-COVID, but in the COVID lull. And we are seeing quite a few newspaper articles about patients who have survived. And this is one typical headline: almost 6 months later, I still feel the effects. And what this draws on is the negative impacts of ICU delirium and neuromyopathic problems faced by patients who've had undergone prolonged ventilation and prolonged periods of sedation. As early as 2006, Dr. Wes Eli in the United States noted the predictive value of ICU delirium on mortality in ICU. And he noted this, and subsequently in a recent article in Critical Care Journal, Dr. Eli and his co-workers went to great lengths to talk about how tailored sedation strategies were very important to reduce the effects of critical care delirium during COVID. And they have been very eager that we would adopt, as a community, a worldwide community, tailored patient strategies for sedation, and in the hope to reduce ICU delirium. I can recommend their website, icudelirium.org, and this is quite often updated for professionals as well as the public. But it gives some references and help if in designing some of these strategies. So, in conclusion, and I'm sure you'll be delighted after this long evening to arrive at this stage, neurotoxicity appears to be a real phenomenon, and many of our common agents do appear to be implicated in apoptosis and some degree of neurobehavioral disorder. It is pronounced in developing brains, and there are signals that similar issues arise in older brains. The clinical translation, however, is conflicted, and but the professional guidance is there to tell us that the epidemiological evidence suggests that it is safe to give anesthesia, at least to children, as long as it's not, as long as it's of short duration and not amplified by frequent multiple anesthetics. There is no such advisory for in the elderly population. The other important implication arising out of this is around occupational exposure for our obstetric patients, pediatrics and geriatrics, whether in theatre and ICU. So in conclusion, short single anesthesia is clinically safe. And we'd also be glad to hear that that there is some evidence that some of the newer sedative agents, such as the alpha-2 agonists, dexmedetomidine, may not carry the same neurotoxic effect, and they may at least attenuate it during balanced anesthesia. So at the very end, I'm not expecting everybody to shout out the answers, but I will give I'll give a little time. I'll just go through these 6 questions, and I know it's sort of routine nowadays when people are doing their reading, they try to do their CME questions. So question 1 is, apoptosis is both inflammatory and stress induced? And the answer, of course, is yes. We know from the discussion that there are 2 pathways, both in intrinsic and extrinsic. Question 2, epidemiology indicates that anesthesia in infants is safe under 1 hour's duration. And yes is the answer, and that is the epidemiological evidence, and that comes straight out of the GAS trial from 2019 in the Lancet. Question 3, ketamine improves postoperative psychometric tests. No, there is no evidence for that. And in fact, ketamine has been implicated in apoptosis and to some degree, certainly in animal studies, neurobehavioral problems. Question 4, postoperative cognitive dysfunction is usually reversible. And the answer is yes. Again, it really depends on, it also depends on the patient's precognitive state. Question 5, ICU delirium can be mitigated by sedation strategies. I think the answer to this would be yes, given the research done by Dr. Eli's team. And the 6th question and final, anesthesia discussion with parents is too difficult and should be avoided.
No.
I think that's absolutely.
Yes, thank you so much, Dr.
Yes,
Beige.
and so yes, I'm open to any questions or any discussion.
We have just a few questions. The first question is about the repeated exposure of infant for general anesthesia. Is it possible to avoid this effect on the developing brain? And if the patient needed repeated anesthesia for any reason, is the change of the anesthetic agent can avoid this problem?
Well, I'm going to relate it to the professional body's advice, their advisory statements, and to what I've read in the literature. And there is no evidence that any change in a particular strategy or a particular format of anesthesia, all anesthetic agents have been implicated in apoptosis and to some degree neurobehavioral measurements. The question is, do you believe that this is a long-term issue, or is it something that resolves with time, and particularly in children? The epidemiology isn't there. There is some suggestion from Saul's editorial that certainly whatever brain measurements, loss of brain volume or brain cells that occur, that there's some recruitment later on. Now, whether so there is nothing to say that changing strategy it mitigates any of these effects.
Change between inhalational and total intravenous anesthesia?
Unfortunately, the evidence is also concludes that propofol is also implicated in brain apoptosis. So it probably comes down to the frequency, the closeness, the proximity of anesthesia events. But again, this is speculation, and a lot of it is still speculation.
Okay. There is another question also about the apoptosis, which can be induced by hypoxia or any other brain injury. In the presence of the anesthetic agent, is this apoptosis can be more worse or it can be protective?
Well, the, the, the studies we've quoted tend not to produce hypoxia, but they do. This is one of the confoundings, that hypoxia does cause damage, and is this a synergetic effect, or does it attenuate somehow? There is, again, it's speculation, but some of the authors have speculated that anesthesia with surgery, and particularly if during hypotension, this may not be a good thing.
Okay, yeah. Just a small comment from myself about the cognitive dysfunctions. You mentioned that it may be irreversible, but actually it depends on the severity. If it is just simple delirium and can be detected early, so it can be reversible. If it is progressed to cognitive dysfunctions, it may be more difficult.
Yeah.
But
Yes.
if it is neglected and the more progressed to dementia, this will be irreversible. So it is delirium, cognitive dysfunctions, and dementia.
I would agree with you, Yasser. I think they're you know, in experience, severe cognitive dysfunction appears to have prolonged effects and
Yeah.
may not be reversible. But again, looking at the literature, particularly the literature reviews, quite often what we're seeing in the severe postoperative cognitive decline and the persistent postoperative cognitive dysfunction are people with pre-cognitive or preoperative cognitive issues. Maybe not measurable, maybe not something we've taken into account at the time, but maybe it was there nonetheless.
Yeah, maybe the last point I have to point for it, just as you mentioned, the depth of anesthesia and sedation increase the postoperative cognitive dysfunction. That's
Yes.
why there's a lot of new recommendations about the monitoring of PIS, especially in
Yes.
each patient at risk of postoperative cognitive dysfunctions or long surgery to keep it around 40 or more. If
Yes.
it's less than 40 for a long time, high possibility or high incidence of postoperative decline in consciousness or delirium or cognitive dysfunction.
Absolutely, I would totally agree with that, and I think that bears out from the literature and from our you know, people's experience.
Yeah. Any comment, Dr. Assam?
Yes, please. Thank you, Dr. Yasser. Dr. Beige, I have one question. I am working and walking every day in neuro surgery.
Yes.
And we spend a long time nowadays because we have a fellowship of transnasal tumor resection.
Yes.
We spend more than 10 hours, 12 hours, or even sometimes 18 hours in the theaters.
Yes.
And I am using total intravenous anesthesia for these patients. First of all, is there a difference between using total intravenous anesthesia and inhalation anesthesia for this patient? My second question, is it a matter of anesthesia exposure frequencies, or is it a matter of timing for the exposure? What is the difference and what is the more dangerous? Because sometimes we are receiving children, for example, for esophageal dilatation, and they are coming every week, and they are exposed, and other people or other children burn, for example, and we give them some of the anesthetic, even intravenous or inhalation. So is it a matter of exposure or is it a matter of the duration?
I would think it's my understanding from the literature is it's a matter of probably both. Duration seems to count. The epidemiological evidence is that cases less than an hour's duration, and that came from the gas trial, that they seem to they don't seem to show any increased propensity or increased chance of neurodevelopmental problems. there, the professional bodies do countenance and they do talk about the frequency and the spacing between anesthesia. And that comes probably out of DiMaggio's article, which showed that the hazards ratio for the number of anesthetics that in children under 3, if they have 3 or 4 more anesthetics, they increase their hazards ratio 4 times. Now, does that mean not every child is going to get a problem? Maybe not. It probably also comes down to the, there may be other variables that we're not taking into account, but nonetheless, they're the epidemiological pieces that we do have. So it's probably, in my mind, it's probably a combination of both. The essential thing is it necessary? Is this necessary surgery? And given what you've talked about, esophageal dilation, I can only imagine that this is something the child has to have done. And but surgeons do have to take into account, is this absolutely necessary now?
TIVA and inhalation. Is there any difference?
TIVA, again, there doesn't seem, nobody's made that distinction. Either professionally have given advice to say TIVA is better than inhalational. Unfortunately, as I alluded to, there is evidence that propofol, because it works on GABA receptors, is also implicated in apoptosis. Is it less severe, more severe? The literature isn't there to say.
Needs investigations.
Yeah, absolutely. And for our young investigators, these will be the things that people will be looking at in future.
Thank you so much.
You're very welcome.
Okay. Any comment from any other body? All okay. Saad.
Just give me 1 second. I would like to thank everybody tonight, and it is very, very informative webinar, and I'm so delighted that we have those eminent speakers tonight. And I want to share with you on Sunday, if you join us, we have a very similar international specific webinar on Sunday. We have 3 eminent speakers. Professor Hani Zahabi is a chair and professor of anesthesia and intensive care in Ain Shams University. Dr. Mu'taz Abdurrahman is a consultant anesthetist in Royal Manchester. And Professor Muhammad Tahan is a professor of anesthesia. And the moderator of that session is Dr. Manal Gohari, professor of anesthesia in Cairo University. So all welcome to participate and share us on Sunday, 13th of September. By this, I would like to thank everybody participating tonight. Prof. Nabil Askalani, Dr. Rory Beige from Cavan, Prof. Assam Manna, and Dr. Yasser Zaglul, Dr. Adil Ibrahim, everybody on board, all attendees, and thank you very much for tonight. And I'm so pleased for that successful session.
Thank you so much.
Thank you very much. Thank you.
Thank you.
Thank you.